our agenda for tonight. We're going to start out. Robbie's going to give us some introductions, and we're going to talk about patient identification and the care pathway, the role for percutaneous PNS, and then partnering with pain management. I think we've got a great combination of surgeon and interventionalist to tell us where this product and this device and this treatment strategy lies.
Thanks, Keith. Really appreciate that. As Keith alluded to, the focus of this talk is going to be the challenging knee patient, and more specifically, the challenging knee patient after total knee arthroplasty. And for those of you that are orthopedic surgeons in the audience and do any volume of joint replacement, you will certainly understand what this is. We all know that our hip patients are very happy. 98 to 99% high satisfaction scores, called the operation of the century, along with cardiac bypass, a really powerful, excellent option for our patients. We know that patients with arthritic knees benefit from knee arthroplasty, but we also know that there's a much higher rate of dissatisfaction. As you can see on the slide here, up to 1 in 5 are dissatisfied with their outcome. In my practice, that sort of led to this obvious question of, okay, I do hips and knees, maybe I should just do hips. All my patients will be happy. They come in at 2 weeks, they give you a high five, they're on their way, and as long as you avoid a complication, they're very happy. But really, I wanted to think about, why is there this disparity between hips and knees? And there's a lot of answers that we can sort of try to think about, but at the end of the day, my goal is to get my knee patients to be as happy as my hip patients are, because fundamentally, the concept of the operation is the same. If you can take away the arthritic joint surfaces and resurface them, they should have less pain. So how do I get them to be as happy as my hip patients? But really, the question is, why is there this disparity? So we often talk about things like flexion instability, patellar maltracking, gap mismatch, and these certainly are all real entities, but like we do with anesthesia, Nirav, this, we like to blame these for more than their fair of problems. So a patient comes in, x-ray looks perfect, everything looks fine, and especially if somebody else did the surgery, you say, oh, well, maybe there's some flexion instability, maybe there's some patellar maltracking, maybe the gaps were misbalanced. And while those things certainly are entities that can exist within a total knee, I think that they get overplayed a little bit. And if you think of it like this. Think of a master surgeon like Dr. Barron. And Dr. Barron does hips and knees, and when he does a hip replacement, 99% of his patients are happy. But when he does a knee replacement, as skilled as a surgeon as he is, he does not get necessarily the same clinical outcome. So for those of us that do high volume hips and knees, why is it that I can achieve excellent technical outcome? The x-rays look good, my intra-op findings are good for both hips and knees, but my clinical outcomes lag behind with total knees. That's really the key nugget to answer. What I'd like to propose today is that this is something that as orthopedic surgeons, we're not very aware of and don't spend a lot of time thinking. When we think about neuropathic pain, I think we tend to think about the, quote, pain patient, complex regional pain syndrome. You touch them, they're jumping off the table. But not all neuropathic pain is as obvious or as exaggerated as I think what we consider when we think about neuropathic pain. Within the pain literature, and Nirav will allude to this later, there's a great deal of data that suggests that some of the pain that patients feel after total knee arthroplasty may be neuropathically modulated. And it's important for us as orthopedic surgeons to remember that neuropathic pain may not be what we are classically trained or actually undertrained on. It's not just CRPS with a red swollen leg that is hypersensitive to any touch and a patient jumping off the table that we tend to dismiss as sort of having, a psychological pain issue. Neuropathic pain is much more sophisticated than that, and I'm going to leave that part to Nirav, but I'd like for us to at least consider that neuropathic pain may be an entity that we should be considering more frequently in knee arthroplasty. I do want to take a minute, though, to not overlook the need to evaluate for orthopedic and surgical causes of pain after total knee arthroplasty. So for the knee surgeons there, this will be very, very familiar. Obviously, if a patient is coming back to you after a total knee and is having pain, the first things you need to do are rule out orthopedic and surgical causes for this pain. Infection, loosening, malalignment, instability, fracture, blood clot, and a host of others. The point of this isn't to push off patients that are having pain after surgery. It's to be able to deal with those patients that have the, quote, perfect knee that we can't find anything wrong with that are still having pain. So for the pain physicians that are in the audience, again, if you are seeing a early post-op or any post-op, frankly, and you are concerned that there's something else going on beyond neuropathic pain, you need to hold the operative surgeon accountable to make sure that those issues have been ruled out before we start going down the neuropathic path. If we can rule out these causes, I think that a large proportion of our patients that have this mystery pain when everything else is technically sound are worth having at least an assessment for neuropathic pain. As I said earlier, if you're a pain physician and you're unsure or you think there's something else more serious going on, send it back to the operative surgeon. This is our responsibility. The goal isn't to pass off our patients that we can't figure out to you. It's to help collaborate once we know we've been able to rule out organic issues with the knee replacement itself. Ultimately, the way that this has worked really well for Nirav and I is that we have a collaborative relationship. I don't just send patients to Nirav. I send him a message or I give him a phone call, and after he evaluates them, he gives me a phone call back. And really, this leads to the best outcomes. We don't ever want to miss anything. And you know, I don't have the training that Nirav has in diagnosing neuropathic pain, and Nirav doesn't have the training I have to eliminate you know, surgical or orthopedic issues with the knee. So this is not an idea of just dropping them off at the pain physician. It's having a collaborative relationship where there's communication both ways. This is a little bit of a busy slide, but I want to give a little bit of a shout out to the pain team. I think that as orthopedic surgeons, we think of the traditional pain doc as like the person you send the person when they, you know, either preoperatively if they're taking 10 Norcos a day, or after surgery and they can't get off pain meds and they just want more and the 90 days is up. But I want us to realize that our pain doctors are much more than narcotic med managers. And of course, there's different types of pain physicians, but when you have specialists in neuropathic pain and peripheral nerve stimulation, like my partner, Dr. Shah, I think that they can be very useful adjuncts to what we want. And this is a rare situation where we really have a symbiotic relationship. You know, if you ask my PA who thinks that I do everything right, and if you believe that, I have a bridge to sell you, but nonetheless, if you ask her what are the most challenging patients for us to deal with in our clinic, it's those knee pain patients that keep calling, that keep having pain. We've seen them 100 times. Everything is fine. It's perfect, but they're still having problems. So, you know, this is something that is a benefit to all of us, in that the pain docs want these patients. They want these patients. We want to move them off our schedule, not because we don't care about them, because I don't have anything else to offer them. I don't have anything else that I can give them to make them feel better. At the end of the day, sometimes it comes down to this second to last point. Do I just say, hey, keep waiting, maybe it'll get better. I know it's been 6 months, maybe it'll be better at a year. Or do I say at a year, maybe you can just live with it the way it is. It's better than it was before. I know you're not happy. So this is really a symbiotic relationship where I can send patients to Nirav that I can't help and that I need to get off my plate. And those are actually the patients that he desires. And I think that that's really a unique thing within this, as that's not always the case in other collaborations. Okay. As a side note, once you get familiar with your pain physicians and kind of get going with this, you can also refer them folks that are non-surgical candidates. And that's not really the focus of this talk, but there's a lot of opportunity for us to collaborate. Just briefly, I will give you a brief rundown of a case that Nirav and I worked on, one of our first cases together on this. A gentleman that I did a right total knee on, went great. No issues, no problems, technically fine, x-ray looked good, intra-op, everything balanced out nicely. Did the same thing on the left knee, same technical outcome. I used patient-specific instrumentation, same size implants. He had roughly the same deformity. Technically, everything was identical, but clinically had a very different outcome. He had immediate acute neuropathic type pain, and this pain endured beyond the time of normal healing. You can see that the gap from when I did his total knee to when I finally got him over to Nirav was quite significant. And that's because I wasn't aware of these options. I tried to nurse him along as long as I could. I said, you know, I obviously ruled out all the bad things, and I said, maybe it'll get better, let's keep watching it. But it actually kept getting worse. And in the absence of any organic issues, clot, infection, I aspirated the guy twice, sent him for ultrasounds a few times. I said, I need some help. And this is where our collaboration began. And after treatment, he literally miraculously improved. This is a screenshot from a video he did where he sort of expounds on the benefits of it. After placement of the peripheral nerve stimulator, the guy got it markedly better immediately, and he's back to his normal life. His outcome on his left knee ended up being the same as the right. My only regret was not sending him sooner, and I won't make that mistake again. So Nirav's going to dive into this more deeply. I think, again, as orthopedic surgeons, we don't necessarily understand peripheral nerve stimulation. It's basically a modality that will deliver an electrical impulse to a peripheral nerve. It remains implanted for a period of time that you'll decide along with your pain physician. And it's cleared to treat both chronic as acute pain, and it's motor sparing. I'll let Nirav talk about the SPRINT system, but the thing that I want to emphasize to my orthopedic colleagues, this is not an invasive sort of, you know, pain catheter that's staying behind. It's very minimally invasive. It's two really tiny little leads, and people don't really even bother or notice with it much. It's not your traditional, like you might be thinking of a spinal cord stimulator that's implanted within them. This is not that in any way, shape, or form. And I'll let Nirav dive into it, but it's very non-invasive to the patient and not really much of a bother to them. So as I said, here's a great mugshot of Dr. Shah. There it is. He likes his glamour shot there. So I have really wonderful pain partners. And again, this is a really symbiotic relationship. This is a place where the people that I can't help, he can, and those are the patients that he likes to see. Not only that, we're actually getting patients better, which is our goal, right? Our goal is to have happy patients that have good outcomes. And this collaboration has really led to a situation where now my knee outcomes are approaching my hip outcomes. They're just as happy as the hips. And I think a lot goes into that, but I do think that there's this large pot of patients that have neuropathic pain after a total knee that are either misdiagnosed or ignored because we don't know exactly what it is. It's the same, the knee looks, quote, perfect technically, but I can't find anything wrong. I think there's work to do for us to sort of further elucidate that, find out exactly what the symptoms are, find out exactly how to diagnose this early and take care of it early, and to figure out actually what the percentage of these people are. But they exist, the pain literature is there, and hopefully on the orthopedic side, we can work on catching up. So at this point, I'm going to turn it over to Dr. Shah to give you a little bit more detail. I would encourage you to please use the chat function to ask questions. These are much more fun and more educational when we're all interacting. So feel free to ask us anything we can, and now I'll send it over to my partner, Dr. Shah.
Thank you very much, Dr. Bashal. Ravi, you've been a great partner in my time here at North Shore. And I'll delve into things by talking a little bit about Sprint. And so in some of the literature that's been done with the Sprint PNS device, it's approved for both acute and chronic pain. So neuropathic pain is what we're targeting in this aspect, but it can be used in almost any part of the body. But I'll try and focus in on just post-TKA pain here. About a third of patients with osteoarthritic pain have some sort of a neuropathic component. There's a concept in the pain world called nociplastic pain, where it's not just purely nociceptive, it's not just purely mechanical. There's a mixed picture. So with neuropathic signaling and abnormal signaling and modulation, these patients can be under-recognized, as Ravi so eloquently put it. Oftentimes it's not that acute allodynic pain. You just lightly touch the knee, a sheet at night bothers them. It's not clear cut like that. These patients don't fit the Budapest criteria for CRPS. Very often they don't. Oftentimes it's just a abnormal sensation that doesn't go away. It's a gnawing. They describe it as a gnawing discomfort, a vice-like sensation. Oftentimes these are the patients who do very, very well, just like Rodney in the previous slides. So, neuropathic pain after TKA affects about 10% of patients, and it's been pretty well studied. The original studies that were funded partly by the DoD in the setting of our multiple wounded warriors coming home from our wars overseas, a lot of these people had blast injuries, traumatic amputations, and they quickly developed what we called phantom limb pain. This technology was applied in that setting and did really well. This is results from a study looking at that. There were randomized control studies looking at that, and as you see, very quickly, just a month in after the start of therapy, you've got a drastic reduction in pain, both for RLP as in residual limb pain and PLP as phantom limb pain, and those two outcomes track out to about 12 months in that setting. Really, what we found is that we've got about 75-75. In the old days, pain used to be 30% is acceptable, 50% is great, and you took what you got and you went home with that. But nowadays, with some of these newer, less invasive modalities, less risky modalities, we're actually getting outcomes hitting 75% of pain relief, and 75% of those have sustained pain relief. So non-neuropathic pain patients can also benefit from this. There are many different mixed picture pain generators. I've had patients who one knee responds well to neuropathic pain treatments, but the other one has a mechanical issue. And that's where I would, like Robbie said, send it back to the surgeon and see if there's something else going on there. Is there a hardware issue or is there a blood clot? You really have to have you have to be a good diagnostician and work collaboratively with your other partner doctors. It's important to have good communication with both your surgeon as well as the patient's PCP, because you need that whole diagnostic breadth of knowledge to really adequately take care of these patients. And in some small pilot studies, Dr. Ilfeld out on the West Coast has studied this and found that pre-PNS to post-PNS, you have very drastic changes in pain scores, even on patients who you may think are just pure osteoarthritic pain. Oftentimes, these patients are complex. They may be on some dose of opioids preoperatively. I've used this technology to actually wean patients down before surgery, and collaborating very closely with your partner physicians, they learn a little bit more about what you can offer as well. So, Ravi oftentimes will see a patient, I think there's knee pain going on, but there might be something in the back. There might be spinal stenosis. It becomes a very fruitful relationship in a way where you can really take care of the patient in a holistic manner. One of our other partners at North Shore had a patient who had pretty symptomatic spinal stenosis, and I was able to do peripheral nerve stimulator to get him down off of the high doses of opioids he was taking. They were not really helping him, but he just kept escalating the dose to the point where, he was having surgery in 4 to 6 weeks, but taking 8 to 9 Norco a day was not going to help him in the long run. We were able to successfully wean him down to about 1/3 of that dose before surgery. I also did a minimally invasive lumbar procedure to correct his spinal stenosis, and he was able to fully participate with physical therapy and do well and really get that maximal and optimal postoperative outcome. We would not have been able to do that had we not had this close working relationship with with our orthopedic surgical colleagues. And in the end, the key to outcomes, and the next slide we'll talk about some of how a little technical view of how this is placed. It's just a needle that places little microwire near the nerve. But the idea is to make sure that it's not uncomfortable when it's placed. If the probe that we place in is dancing when we turn it on, that's too close to the nerve, or it's too far away from the nerve and stimulating a local muscle. So there's a little bit of finesse involved, but well within the wheelhouse of interventional pain physicians and our skill sets taking care of these patients. As many of us are anesthesiologists, we do nerve blocks all the time. So it's a very similar skill set with a few nuances. So this slide kind of just shows the general big picture of how this is placed. On the left, you see where you place it about a couple centimeters down from the inguinal crease. You can do this in an outpatient setting. You use an ultrasound to find the neurovascular bundle there. You can see on the right side the nerve, the artery, and the vein, and just under the fascia lata is where you want to be. So you just come in lateral to medial as if you were doing a femoral nerve block. You get close to the nerve above it towards the more medial side. In my experience, I've found gives you better medial and distal coverage towards the knee. And all you want the patient to feel is confirming a comfortable sensation, a tingling, a pressure, sort of a fullness in the knee area or going towards the knee area. And as I've said, I've used this both preoperatively as a way to get patients in a good prehabilitate patients and optimize them for surgery, as well as postoperatively, far enough out where we don't have any issues with acute healing or anything like that. The device is an excellent safety profile. I myself, nor my 3 partners who do these procedures, have seen any of these major issues. There's never been an infection in either the user data and the studies for the device itself, nor in our personal experience. Some of the reason is because the little microwires it's placed is a microcoil, and it's designed for the body to grow around it and sort of seal it in. No bacteria can track in and out, unlike a pain catheter where a peripheral hollow catheter will be smooth and bacteria can come in on top of it. The biggest thing I've seen is maybe a little bit of itching or the mounting pad where the battery is worn on the body. There's a sticky pad that completes the circuit between the wire, the body, and the device. Some people can develop a bit of an allergic rash to it, but we have since developed a few different iterations of that or coatings to put on the skin to prevent that from happening. So yeah, these numbers are even less in reality now in our practice. So presenting it to referred patient to patients you want to refer to one of us, I think these are some good guidelines of whether you're an interventionalist or an orthopedic surgeon. Just keep it simple. I like to present it as it's a very hair-like microwire that we just place it through the skin with ultrasound, just like the nerve block you would get for your surgery. We just leave the little wire behind. It's not permanent. We take it out in 60 days at most, sometimes sooner if your pain is very, very well controlled and you're post-operative. The little matchbox size battery that you wear, you can take it off to take a shower, take care of yourself, put it back on. The only thing we ask is you don't go, bathing, diving into a pool or swimming for the 60 days while the therapy is in place. The bandage that's put on the skin, we change that every 2 to 5 days. And as I said, sometimes we have to really be careful that a patient is optimized for this type of thing. Now, an elderly person who lives alone, has little help, cognitive issues, may be somebody we have to be a little more careful for. Oftentimes our reps are very helpful and they're able to coach the patient or their caregivers on how to appropriately do this for them. In terms of site of service, we do this, you can do this under local anesthesia only, no sedation is needed. In fact, I would actually say, in my practice, I would say sedation is contraindicated because I want the patient to give me appropriate feedback as to where they're feeling the sensation, because that's how you know that you've placed it correctly. It's not that uncomfortable or painful. You just have to give the patient a primer ahead of time that you may feel sort of a tingling sensation. Will go up slowly from a low energy to a high energy and find a good place for you. So they're not, they're not surprised, you're not shocking them, that sort of thing. In terms of a site of service, typically it's done in an ambulatory surgery center or hospital outpatient setting. Unfortunately, while it totally technically could be done in a clinic setting, due to reimbursement issues, it's not feasible in the actual clinic setting. But I would encourage you to have privileges at either of those two settings to do this device. And for those that are interested, I'll talk a little bit about SPR Care. It's a support system that the company provides. The SPR company has an entire team in the back office, essentially helping get approvals done for these patients. Medicare covers this with no question, but certain insurance providers and private insurance providers in certain areas may have non-updated policies, that sort of thing. So SPR Care can really help with that and even send out external appeals when necessary.
Okay, Nirav, thanks. That was a really great review. I want to be respectful of everyone's time, so I'll try to go through this relatively quickly. But as Nirav was going through it, I kind of thought of the three main points that I wanted to get across. Number one, if you're an orthopedic surgeon, what's the debate here? If you have a total knee that you've ruled out for all the other causes, what is stopping you from exploring this option? You owe it to your patient. We all know it. If you do enough total knees, we have those patients that just aren't happy. You've ruled everything out. This is a low risk, high reward proposition. So, what are you got to do something with these patients, and the old adage of, well, you're just gonna have to live with it, probably isn't good enough. Okay. Number two, if you're a pain physician, what are you doing to educate your orthopedic partners about this? We're dummies. We don't know about this. We just use hammers and saws and really are not educated about this. Okay. Nirav always brings up that British Medical Journal about orthopedic surgeons being, smart as an ox and twice as strong, or however that goes, although the data there did prove differently. Nonetheless, we need your help to learn about this. So if you're a pain surgeon, pain physician, what are you doing about this? And finally, the other main point was SPR Care is important. As orthopedic surgeons, I don't want to be bothered with reimbursement. I don't want this to be a burden on my patients. I don't want it to be a burden on my system, and I don't want it to be a burden on our bottom line. There's a robust support system to make this easy. No one wants to be making these phone calls and doing prior. We already do enough of that with what we do. Use SPR Care. It's great. I'll briefly go through these slides. Here's the deal. We know that if you're not doing well early with your total knee, you're not going to do well. Okay. Again, excluding if you have an organic cause for this. So, if you don't have pain, if you still have pain at 6 weeks, it's unlikely to be dramatically changed at 6 months. Meaning, if you're doing terrible at 6 weeks, you're not going to be doing amazing at 6 months. So, I was always taught by my mentors, tell your knee patients, hey, we're going to hold hands for a year. Things are going to get better for a year. Yes, there are small things that can improve, but you and I both know if the person's doing terrible at 6 weeks, they're probably not going to have a great outcome. So, intervening early is important, again, in the absence of organic problems. Again, I'll just go through this quickly. I think as time goes by, we'll be able to better identify these patients, but the folks that potentially might have trouble beforehand: chronic opioids, fibromyalgia, more work to be done on this. Next slide. Again, timing, we don't want to, the key here is don't miss an infection. Don't not see the patient and send an infected, pussed out knee to Nirav to treat neuropathic pain. We want to exclude these things, and there is some patients that need to be exhibited by both the patient and the surgeon to make sure this isn't going to go on its own. I'm not advocating sending a 1 week post-op knee to Nirav, but waiting for a really long time also increases your risk of manipulation, as we saw on an earlier slide, increases the risk of a poor outcome. So don't be hesitant to start intervening. As a side note, we all see patients that aren't surgical candidates, and as surgeons, as we're being more closely scrutinized, our indications have tightened in that patients that are high risk, depending on your philosophy, may or may not be appropriate candidates for an elective total knee. So if you have an obese smoker with diabetes and an A1C of 10, you may choose to operate on them, or you may choose not to. And if you choose not to, again, you can be a better doctor by giving them another option, as opposed to saying you're too fat, you smoke, and your diabetes isn't controlled. Come back when that's better. Yes, present them, tell them the information, but present them with a solution, which in this case could be nerve stimulation.
Keith, as you mentioned, sometimes, and Ravi, that the PNS is a solution, not a Band-Aid. You know, you get out 60 days, 90 days out, and if you're having these issues, you don't want to wait, you know, months to a year. The main reason is many of us interventional pain physicians have seen that the longer you don't treat neuropathic pain, the harder it is to treat. In the end, you're kind of chasing it. So early aggressive intervention, either chemically through these medications, electronically through you know, neuromodulation, you know, whether it's spinal cord, peripheral nerve, DRG, whatever it is, lumbar sympathetic blocks. There's a number of things that your interventional pain physician partners can try.
Robbie, have you had any experience with the perioperative utilization as opposed to just the tough patient?
Yeah, we've thought through it a little bit. You know, I think that's an area that we're evolving. We've tried it on a couple, and I think, as you said, we really noticed a decrease in opioid consumption post-operatively, and they are generally much happier. I think that as we do a better job identifying the patients that will benefit from this, both pre and post-operatively, I think there's going to be a way that we can stratify and sort of group these patients and say, okay, you've got these, just like we do with DVT. How do we choose your prophylaxis? There's a score. I think we'll be able to do a neuropathic pain score or an opioid score. And some of our research in our institution is looking at genetic markers. I think we put it all together, we're going to be able to identify them. So I'm not taking the approach of shotgunning it to everybody at this point. I do think that once we narrow that field, we're going to be able to really identify the folks that will benefit from it pre-op, and save the resource for those folks over everybody that may or may not need it.
I had not thought of it for use. Like today, I saw a BMI of 47. She desperately wants to continue to lose weight. She's lost weight. She totally needs a total knee, 2 total knees. She doesn't feel like she's ready yet. I'd like to see her lose some weight, but she's in horrible pain, and those patients present a real big challenge because you can't just keep hitting them with cortisone. It stops working after a period of time. The question I have for you, Dr. Shah, is when I send those folks up, my anesthesiologists look at me pretty funny. Talk about obesity and particularly the sciatic lead, but maybe they don't need that if you're just doing the pre-op sort of conservative care pain. Tell me about that.
Yeah, so it's a technical thing. It's really just a technical thing. You have a large leg, a large amount of tissue, and the ultrasound beam can't get very deep past that. So if you can't see where you're going, it's not safe to put a lead there. Obviously, as you develop your skill set, as you have better technology, et cetera, depending on which practice you're in, you might be able to get a lead to the right target, but it can be a little tricky, like as you said, especially for the sciatic nerve, where where are you going to put it? You're going to put it down by the knee. If you put it down there, can it be really used perioperatively? No, because your turner gets in the way. So it's one of those things where patient selection is key. So if you've got a thinner patient who you can get subgluteal access to the sciatic nerve, or they don't have a very large amount of tissue just inferior to the inguinal crease, that's where you can do it. And as a surgeon, that's kind of one of the things that, like, you can think about that and say, look, I'm not sure they're a candidate, but what do you think? And even if they couldn't, even if they're not a candidate for that, they're a candidate for other things like genicular nerve blocks and radiofrequency ablation, et cetera. There's always there's multiple ways to treat that knee pain, even if PNS isn't the right answer for that patient.
Keith, to follow up on that,
go ahead.
I was just going to say, you made a great point. I think that addressing, if you have somebody that's a non-surgical candidate, especially if it's weight related, it's much harder for them to lose the weight when they are in pain. Okay, not just because of exercise. We know it's all diet, calorie restriction, but they're depressed and they're not happy. So one of the things that I've noticed is when I utilize Dr. Shah and whatever method he wants to use, whether it be ablation versus nerve stimulation, for these non-surgical obese candidates, they tend to have a higher rate of success in terms of bringing that BMI down and coming back to see me. And I think that's something that's really important. We got to find a way to care for them as opposed to just saying, sorry, you're too big, go away, figure it out. I think that we can really empower them to be able to get into the shape so that they can have a successful operation.
The concept of prehabilitation. That's what I like to do with these patients. And then when they're teed up, I send them back to Ravi. You know, if they're on opioids, I try and wean them down by 50% or at least less than 50 morphine equivalents. And those are the ones who do really well based on anecdote as well as evidence.
As we've transitioned and as we've started to do more of these, we started with the sciatic up high, whatever you called that, subgluteal or whatever. And we actually now do it purposely relatively distal. It's coming out the posterior lateral side of almost halfway down the thigh. And we've got a dressing that we put over it in pre-op. This is for the perioperative use. We have a dressing we put over it in pre-op. We've educated the whole staff that when you have one of these, you put this dressing on, you prep right over it, put the tourniquet right on wherever it goes. And we've not had any disruption having implemented that protocol. And it does make it much easier on anesthesia to do these much more efficiently when they're inserting them, and just ease and safety in those heavy patients. It would seem that if it helps 75% remaining symptoms at a year for someone who's had their leg cut off, it ought to do pretty good at a year for back pain or knee pain or shoulder pain or whatever.
Absolutely.
So,
I mean, that is some of the hardest pain to treat. You know, I've seen spinal cord stimulators fail at that in my fellowship training. One of my first candidates was actually a femoral subgluteal sciatic 2-lead device in the very early days when we first got access to the technology. Lady had a fusion from T7 to sacrum. I mean, there was nowhere to go. You couldn't do a spinal cord stimulator. So in this case, that was the only option I had. And she sent me this really sweet message. She was back. She was, you know, no longer depressed, minimal pain meds, going to church, standing up, singing the Ave Maria, you know, etc. So it was a very, very, very nice message to get from a patient. When you see a paragraph in your in basket on your North Shore connector, you know, what we call our Epic in basket, you kind of just internally groan. You're like, oh my God, I wonder what this is about. You know, because when you're treating chronic pain patients, you often get very lengthy, harsh feedback at times, but this was like the exact opposite. So I actually have it saved. I might frame it for a bad day.
Well, with that good story, we're coming up just right on. It's 8 o'clock your time, 9 o'clock mine. I don't see any other questions on our list here. I want to thank Nirav and Ravi for their time tonight, their expertise, and really showing us the collaboration between an interventional pain management physician and an orthopedic surgeon, and how fruitful that can be, most importantly for our patients, in terms of offering something to them that can make a huge difference.